All right, well, let's get started. We have gotten about halfway through this adjusted set of readings for Reed, and we now are ready to begin our discussion of England. We're going to cover that and Canada, point out again some important differences that separate the United States from these other countries, and then end with two countries which came to reform late in the 1990s, Taiwan and Switzerland, and say a little bit about that. And the irony, cruel irony, I think, that when these countries were moving towards health reform late in the game, the United States was attempting to reform its health system, which collapsed. That was the Clinton efforts to reform health care, which paralleled chronologically those other efforts, but our outcome was quite different. So let's get back to this set of countries. England, which was first in the film. It's the country which is closest to having a truly socialized system, that is, of those we've studied. Could have said the same thing about Sweden or other countries, but of those we've studied, it's the closest that has a truly socialized system, which means it has relatively high taxes, but English citizens get a great deal as a result of those taxes. It's invested in a variety of social programs and social safety net programs, with which the English seem generally quite satisfied. In fact, the protest shown in the film was of people who wanted the English system to stay the way it was, rather than to move it more in a privatized American direction, which those who were protesting thought would be the worst possible thing to happen, not a good aspiration. There are, admittedly, sometimes waits, sometimes long waits for elective procedures, and there are sometimes exclusions of particular procedures or medications, etc., or tests within the system. But compensating for that, and those aren't necessarily terrible things, but they're things to reckon with. In any case, compensating for that, the system overall is extraordinarily inexpensive in comparison to the United States. It pays 1/3 per capita of what the United States pays. That's an amazing difference. And yet, produces outcome results that are generally better than the US. Now, that's not all the result of access to health care, as we know, and there are many important social safety net provisions which are other than that that contribute, but nonetheless, those are the facts. 1/3 the per capita investment and better overall results, which is quite extraordinary. Overall, the National Health Service, as far as anyone can tell, based on surveys and other research, seems to be popular among the British public. There are always going to be those who complain and have particular grievances, but overall it seems popular. And even Margaret Thatcher, who was a very conservative politician and prime minister in the 1980s, coinciding in ideology and chronology with Ronald Reagan in the United States. It was part of a big, quote, neoliberal, unquote, sweep. That's for another conversation in the world in that decade. Even Margaret Thatcher, who tried to cut the NHS back, was not really successful. She was stingy about the budget, but her direct assault on the National Health Service failed, as did Reagan's attempt to really attack Medicare. He backed off. There were awful Reagan cuts that affected very vulnerable programs like Medicaid and other social programs, what we generally call welfare, what was provided for poor kids with school lunches and job training programs. A lot of that was the legacy of the 60s and continued through the 70s, was cut back significantly by Reagan. But when he tried to cut back Medicare, he was faced with a massive opposition and backed off. It led to a very interesting alternative approach to try to get the Medicare budget under control, and that led to the very significant transition from cost plus retrospective reimbursement to prospective reimbursement, the DRG system, a kind of fee schedule that began to really take hold for Medicare reimbursement and elsewhere in the U.S. health system in the 1980s. That was as an alternative because he couldn't do what he wanted to do and he had to try to save expenses somehow. We'll talk about that next week. It's a very significant transition point as we look at the U.S. health system in the last 50 years or so. When the Labor government came in the 1990s, replacing the Conservative government, Margaret Thatcher and some of her successors, Tony Blair, as the leader of that government, was successful in restoring some of the funds that had been cut from the National Health Service. If you remember, you see him on film addressing one of those wonderful sessions in the British Parliament when Prime Minister's question sessions, they actually broadcast these on PBS, at least they used to, regularly, and they're wonderful because the exchange and the wit is extraordinarily clever. The British politician really, really has to be very, very smart and very informed because he's peppered with questions from everywhere, and they're all sitting in one big room, sort of around a giant table and seats on the side. And they have to be very quick on the uptake. They showed one of those sessions in which Tony Blair said, we have restored these funds to the NHS, and we are seeing dramatic improvements and cutback in wait times, and so on and so forth. If you want a very rigorously peer-reviewed version of that same story, you can go to the New England Journal of Medicine, which published an article, it's very interesting timing, September 9th, 2009, by two British physicians, Kerr and Scott, which reported on the following: British lessons on healthcare reform. The timing is interesting. Why did the New England Journal of Medicine publish this report from England in September 2009? Because we were coming down the stretch in the big battles over the Affordable Care Act, over Obamacare, which continued through late 2009 and finally reached a successful outcome by a squeaky thin margin in early 2010. So this was in the middle of that, and lots of people in the U.S. debate were saying, look at that terrible situation in England. That's what's going to happen if we move an inch towards Obamacare. And they started telling these familiar horror stories. Well, these two British physicians were upset and outraged by the distortion of the reality they knew from the British system, pulled together some data, wrote an article, and the New England Journal of Medicine, which generally has a pretty progressive attitude, and departed back in the 60s officially from JAMA and the American Medical Association, said, no, we got to publish this. It's not true. The American medical profession, American politicians have got to face the reality, which is quite different from the way this propaganda version is being played. So here is a little bit of what these two British physicians reported in the New England Journal of Medicine in September 2009. They said, when the Labor government came to power in 1997, it recognized that health care spending, that's the more progressive government of Tony Blair as opposed to the Thatcher government, it recognized that health care spending was inappropriately low. Britain's total expenditure on health care then was 6.6% of its GDP, compared to what was twice as much in the United States at that time, 13.4%. In the intervening decade, that is between 1997 and 2007, Britain has made major investments in its healthcare system, following the priorities of the Progressive Labour Party, raising the total expenditure to 8.4% of the GDP in 2007. Doesn't seem like a great change, but 6.6 to 8.7 of GDP, 8.4 is quite a significant change in real dollars or pounds. These funds, which effectively doubled NHS spending from $75 billion to $159 billion per year, have been used to build new hospitals, hire more nurses and doctors, provide an improved base for physician salaries linked loosely to productivity, and enhance the research infrastructure in order to generate a stronger evidence base for clinical guidelines. Has this investment significantly improved the quality of care, they ask? Answer, absolutely. There have been massive improvements in waiting times for care and in general patient satisfaction with the NHS, as well as real improvements in outcomes as measured by the usual quantitative indicators. For example, fewer deaths from cardiac causes and from cancer, among the other important quantitative indicators. So that's what seems to be the reality in spite of the scare stories used for propaganda purposes. What else is in the chapter in Reed are, let me give you some highlights. There's an interesting historical account of the way Britain got to the National Health Service, an outline, of course. It focuses on Lord Beveridge and his report in the middle of World War II, which gave the British something to look forward to after the horrors and atrocities of World War II. Britain was the scene of direct combat within World War II in the sense of bombing raids almost every night, vast devastation, buildings turned to rubble, people having to go down to the tubes, the London subway system, for air raid shelters in order to survive. And in that mentality, the general notion of the government is, we will give you something to fight for, to survive for. If British persists, if the British spirit survives this, then you have the right to look forward to a better life after the war. And part of the better life is an expanded and deepened safety net, including a national health service, or national health system. The National Health Service, which was the more progressive version of what Beveridge originally suggested, did suggest additional coverage, but would have done it in a completely insurance mode. The more progressive version, the National Health Service, as a more socialized system based on tax revenues, emerged because of a shift in British politics that came right after the war. The British public wanted to hold on to its conservative leadership under Churchill, who was an inspiring prime minister, but who wasn't so good on domestic policy. And the British voting public knew that. As soon as the crisis of the war was over, they voted Churchill and his party out, and they voted the Labour Party in, whose leader was at that time a fiery guy who had come up from the coal mines of England and Wales, named Andrew Bevan. And it was Bevan who pushed very hard to create the National Health Service, which was voted in 1946 and became actually up and running by 1948. It's very interesting parallelism, again, if we look internationally, at just the time that the United States was going off the rails as far as health reform, in the middle of its ferocious McCarthy-era Red Scare and derailing again, Britain was pushing forward and moving to a very progressive version of a national health system. If you look at the account carefully, which is generally on pages 106 to 112, there are some interesting particular points that I think are worth noting, at least in passing. On page 111, Reed mentioned something called the Emergency Hospital Service, which was created during World War II. And that created a significant post-war precedent. That is, under emergency circumstances, governments have the authority to do things they never do in non-military or non-wartime circumstances. The United States did this by creating the War Labor Board and did various things with wages and prices and benefits and so on. In Britain, they went beyond that, and actually the government took over the hospitals. Many hospitals were actually being bombed and put out of service. They needed to consolidate resources, they needed to mobilize, and the government, even a conservative government, in a wartime emergency, took over the hospitals. The memory of that carried over significantly into the post-war period. The government has a role, a significant role perhaps, in creating a countrywide system of hospitalization and medical care, and it's not such a strange, weird idea. It worked very well during the war and may have saved us in medical terms. That's page 111. Page 112 is just a passing mention to an interesting political tangle that Bevan, a socialist, a member of the Labour Party, got himself into with a group of physicians. Because Bevan, in order to deal with the pushback of the British Medical Association, representing Britain's GPs, which didn't like some of the proposals coming down the road and try to fight against it, much like the AMA has done in the United States. The BMA was doing similar kinds of things, and they didn't like that Bevan, in order to try to move forward, was beginning to contemplate certain concessions to the insurance industry and so on. They wanted, this particular group of physicians wanted a more truly socialized medical system. Maybe a little bit like the model of the Soviet Union, which had such high regard in the 1930s and 40s. This was a group of physicians whose initials were SMA, page 112. It was the Socialist Medical Association. And it's so striking that in Britain there could be such an entity as the Socialist Medical Association, a group of strong-minded, strong-willed, competent physicians who were also overt, direct, and very militant socialists who wanted the medical system to be more left rather than less left as proposed by the British Labour Party. The notion of a socialist medical association in the US context is an oxymoron, a nonsensical phrase, two words that don't go together. But in Britain and in other European countries, it makes perfect sense. There are fairly strong contingents of left-leaning socialist physicians, and they obviously are part of a political mix in pushing countries to have more universal systems of various construction. Another part of the chapter that's interesting is that there's a discussion of an entity in Britain which is abbreviated NICE, N-I-C-E. And it's a way of keeping British costs down. NICE stands for the National Institute for Clinical Excellence. That's N-I-C-E. The actual name is for Health and Clinical Excellence. The health is silent. Doesn't help fit the acronym so well. But what NICE does, the National Institute for Clinical Excellence, is very carefully, with the very best data, with the most careful analytical quantitative analyses, evaluate the cost effectiveness of drugs and medical procedures. And then, because it has this central authority, once it does its studies, makes that the basis for enforcing what will be reimbursed and what not, which saves overall a lot of money. In the United States, we have a great capacity to do cost-effective analyses, and there are agencies in government that actually fund such analyses. Various people do this as their academic work. That's what the whole field of health services research is in large part about. It's not the only thing it's about, but that applying these quantitative methods. It's kind of Archie Cochrane writ large, if you like. But what is different about the United States is that often the recommendations that come out of the studies are merely recommendations. Maybe we'll try this sometime. There is even in the Affordable Care Act some language about and some funds directed towards creating more cost-effectiveness studies. But the language is very, very loose and weak. It's very weak swill compared to the strong brew in Britain. And what's left of those studies is, well, maybe we'll consider someday applying, blah, blah, blah. But it's not in any way tied to actual budgeting and actual methods of making decisions about what will be funded and what not. So that makes things quite different. Sometimes people get upset by the kinds of decisions that are made. But as Reed points out, even when there are protests or when there's unhappiness about a decision not to fund such and such a procedure because it doesn't seem cost effective, that protest is quite muted in England because there is a widespread understanding throughout the country, throughout the public, that the government is really trying to stretch its limited resources as best it can for the good of all and not for private profit. When such denials happen in the United States, they are often at the hands of a private company, so we're not going to pay for that, we're not going to fund that, and so on. And that's because we're going to preserve our profit-driven bottom line. When that happens in Britain, it's understood that it's an attempt to spread the resources most effectively and to make the best decisions in very, very hard and difficult circumstances, which everyone acknowledges. There's a good example of that that Reed discusses on the bottom of page 117, top of page 118. He says, there's a set amount of money in the National Health Service system, and somebody, it's NICE and the people who apply its findings, has to decide what it should and should not be spent on. Someone's got to make that decision in any intelligent, rationally run system. The U.S. runs from that decision, and that just creates all kinds of places and loopholes for profit to take over and for people to be deprived of need, not based on really thorough analysis, but based essentially on private greed. Because the NHS budget, read continues, bottom page 117, covers everybody. The money saved on one patient can be used to treat another. Declining to operate on a sick grandmother means there is more money available to treat sick children. Accordingly, protests about denied coverage tend to be muted. In the U.S. system, that trade-off doesn't apply. If an American insurance company refuses to pay, let's say, $36,000 for Herceptin for one of its clients, the money saved is likely used to enhance profits. It's not going to go to an infant covered by some other family on that same plan. Yes, you have a question.
What is the process for patients in the UK to obtain services that aren't approved by NICE?
It's not covered by NHS. If they want to, if they have the resources to pay for it, they can.
Are there providers, healthcare providers, that would provide those services to patients?
There's a growing number, and there is a drift towards privatization, and that's exactly why that protest in Trafalgar Square happened, because NHS seemed to be embracing that too much. But any person who has the means in Britain who wants to get that can get it, but it won't be covered by the NHS if NICE says it's not cost effective or not put in our priority list.
So they would have to seek services from a physician that's privately employed and not employed by the NHS?
I believe that's the case, that someone in NHS can take both. Okay. I'm not sure whether they're allowed to have separate sets of patients. I don't know that detail. Someone has worked, some of you have done internships in Britain and done some work there within the British National Health Service. You might have a better answer. I don't have that. Anyone have some information about that? We always have students going to London abroad and getting at least some sort of NHS experience. In any case, there are a few surprises for an American. Reed tells the story that his company, which was the Washington Post, would have been paying for any kind of private insurance that was available, private physicians, but he declined to have it. The family deliberately chose to be on the NHS and stick within its rules, and they thought that they were very, very well treated, although a few things surprised him coming from an American perspective. It's typical when you go for an annual exam, men of a certain age will automatically have a PSA test, which is a test to assay some indication of prostate cancer, even if there's no indication on a physical exam and so on. They don't do this in Britain. And that had to be explained to him by his primary physician, Dr. Badat, we saw on the film, that NICE has done the analysis. They've done it very carefully. They've collected all the data. And they have found that the PSA is not a very good test. There may be more false positives than are warranted, and we just don't think it's worth the money. And in fact, they were well ahead of the game. That is now the case in the United States. PSA tests are much less generally used than they were before, and there are other indicators and measures that are used to test for prostate cancer. So in many ways, they may be ahead of our system, even though it's quite surprising. Also, there are fewer x-rays and so on, and that might also one day come to the United States. But I have to shift quickly now. I'm trying to rush through this to Canada. And there's a good overview of Canada's what could be called a single or 13-payer system. It's single-payer in principle, that is an entity, a government entity that collects the resources and reimburses providers. The system is private. Physicians are private. Hospitals are private by and large. There are a few public hospitals, as in every system, just as we have here as well. But by and large, they receive their funding from a government entity. Actually, each province, there are 10 of those, and the 3 territories, 3 more, can arrange its own special version of that as long as they stay within general national guidelines. So it's really a single payer system that has 13 different flavors. And the flavor in Ontario will be different from the flavor in Quebec and so on. But those are variations that are tolerated and encouraged within the Canadian system. Canadian system provides a one-tier medical service for all Canadians. There aren't two tiers, the privileged and the less privileged. For most conditions, including all emergency conditions, at a very high level of competence and with quite decent amenities. As a personal note, my daughter studied for 2 years in Toronto, getting a master's degree, and as the rules had it, she had to be covered by the Canadian system. There was a student buy-in, etc. And so I got to see very, very closely the kind of system, the amenities, the competence of physicians, and so on. My daughter has an ongoing chronic condition which has been managed very well, both in Rochester and then in Canada, in Toronto, and now in New York City. And in each case, I got to know the provider and provider institutions very well and made sure there was a seamless transition from one to the other. And I can assure you that she got care in Canada that was at least as good in quality as the care she had gotten in Rochester, and it was at literally 1/3 the cost of her buy-in to the Canadian system. 1/3 the cost, equal quality. That tells you something. People want to tell anecdotal stories. Put that anecdote in your pot too. I am a big fan of the Canadian health system. Canada's great virtue, Reid tells us, is that it has a sense of strong moral obligation to egalitarianism, which is very widespread throughout the culture. Canadians are so polite, and part of that politeness is partly, obviously, a trumped up sort of stereotype, but it also does really seem to come to pass. And certainly in my dealings with Canada, there were very few aggressive Canadians pushing their way to the head of the queue in anything, in a movie theater, in a restaurant, or in the health system. There are people, I'm waiting my turn, thank you. Oh, go right ahead. And that is maybe to a fault, but there is this sense that I'm not going to worry about pushing to the head of the queue. I'm not going to use my connections, my aggressiveness, my perhaps private resources. That's not fair. Canadians as a culture are committed to a sense of fairness, and this comes out in the discussion very, very clearly. So what we have in Canada is, compared to the United States certainly, a relatively cheap, efficient, much loved system for most things. Now, one of my colleagues in the medical school is a Canadian. She's head of the medical humanities program here at the University of Rochester, an MD, PhD. And she's now getting to the point where she has to start thinking about retirement. And she says, my God, if this country continues to go the way it's going, when I'm ready to retire, I'm going back to Canada. I can't, I'm not going to stay here. It's crazy. And I've kept my Canadian citizenship. So she's a dual citizen now and has the right to do that, which I think a lot of Canadians who live and work in the United States for some period of time do. There are some things which can, of course, lead to frustrating waits, such as hip replacement surgery or any major orthopedic surgery. But then again, I can point out that in the United States, even in a community such as Rochester, which has very abundant and robust medical resources, you can wait 6 to 9 months for a particular orthopedic procedure, even if you have the best insurance covering it. It's just that it's a queuing problem that results from the numbers of providers and resources and the number of people asking for that service. What Reid adds to that notion, yes, there is a queuing for non-essential things, no question. But there are 3 important qualifiers about the Canadian system. First is the Canadian attitude about queuing, which Reid uses Uwe Reinhardt, his Princeton health economist that he studied with. He talked about Reinhardt, who was one of the great and most respected health service researchers and health economists working in the United States. Reinhardt understands the Canadian attitudes well, because that name Reinhardt sounds German, it is. He was born in Germany. Family moved to Canada. He grew up in Canada and went through primary and secondary and university education in Canada. Then came to the United States, did a PhD in economics at Princeton, and stayed on the faculty for another 40 years or so. That's Uwe Reinhardt. But he remembers clearly what Canadian attitudes were like. He probably still has family and friends and visits them and so on. And this is what Reed quotes him as saying. Most Canadian, page 130, most Canadians deal with a waiting list by, guess what? Waiting. That's what Canadians do. Statistics suggest that those who need care urgently can get it. But anybody whose problem can wait will wait, sometimes mollified by the awareness that everybody else is waiting too. As Reinhardt says, Canadians don't mind the waiting list so much, observes Princeton economist Uwe Reinhardt, who grew up in Canada, so long as the rich Canadian and the poor Canadian have to wait about the same amount of time. It's fairness, after all. You can't push your way to the head of the queue by having additional resources. If people have to wait, they wait on the basis of medical need and available resources, not on the basis of whatever privilege they have to throw their weight around. Another, yes?
Yeah, isn't the Canadian wait the queuing problem due to they don't have enough primary physician? Because
no, these are primarily for more specialized procedures, orthopedic procedures, some cardiac procedures, and the like. So these are not primary physicians; they're tertiary physicians. Okay. Now, connected to this notion of queuing is a very widespread notion that those Canadians who get impatient of waiting and have the resources, they are from wealthier families, have more family resources, go to the United States to get treatment there. They're not going to get stuck in that Canadian line. That's why there's not so much grousing, because the people who would be most inconvenienced and most unhappy about it and have the means can jump out of the queue and get their service in the United States. And so there's a suspicion that Canadians, especially those who live close to the border, will travel south and get their care in the U.S. if they're on the west coast of Canada, a major medical center in Seattle, one of the best in the country, or they'll go to the middle of the country and they'll go to Minnesota, or they'll come down into New York State or New England, etc., depending on where in Canada they're living. But in fact, as Reed reports, the actual facts indicate that that doesn't happen. It doesn't really happen. On pages 129, bottom, to 130, top, he refers to an important study by Katz and colleagues that was published in the very respected Health Affairs, the journal, the health policy journal that is very, very highly regarded, especially within the Washington Beltway. Lots of people, congressional staff, the congressmen themselves usually don't take the time to read it, but they have smart staff people who read it and digest it for them. The congressional staff reads it, and that's the journal in which these Canadians, Katz, etc., published an article which they gave the wonderful title to, Phantoms in the Snow, Canadians' Use of Healthcare Services in the United States. They call them phantoms in the snow because they don't really exist. They're supposed to be creeping across the border in the snow, but you can't find them. You can't find their footprints, and you can't find their records in U.S. hospitals. Reed summarizes the results of their study, bottom 129, top of 130. Let me just read you Reed's summary, then I'll go to the original article. The article is cited in one of Reed's footnotes, and in fact it's footnote 4 on which is on page 130. The actual text of the footnote is on page 276 in the book, which brings you to this Katz et al. Article. It's how I found it in the first place, by chasing down Reed's footnotes. I wanted to check out his references. So this is what he writes in the text. It has been widely reported on both sides of the border that millions of Canadians stuck on the waiting list traveled to the United States to pay for the care they could not get in the Canadian system. In fact, though, the race to the south is mainly fictional, not supported by any statistical research. Expert studies of the healthcare refugee issue have concluded that the actual number of snowbirds flying south is tiny. Mostly Canadians deal with waiting by waiting. And then the reference 4 takes you to the CATS article, and this is what the CATS article reports based on their close, rigorous statistical analysis. And I'll just give you a few tastes of this article. All right. The abstract reads, to examine the extent to which Canadian residents seek medical care across the border, we collected data about Canadians' use of services from ambulatory care facilities and hospitals located in Michigan, New York State, and Washington State. That's the sort of the southern drift in the period, and they give the period of the study. Results from these sources do not support the widespread perception that Canadian residents seek care extensively in the United States. Indeed, the numbers found are so small as to be barely detectable relative to the use of care by Canadians at home. And then they give you detailed analyses of what they actually found, and the results are really quite amusing. Sure, there are Canadians in U.S. hospitals in those locations, but they're not there. Those Canadians that you find in U.S. hospitals are not there because they were seeking care they couldn't get in Canada, but because they had a medical episode or accident while they were in the United States, and that was the closest hospital to go to. Like Dr. Vidal having some episode, a stroke or a cardiac, whatever it was, and being taken to a hospital when he was in Las Vegas. So you have foreigners going to you. Canadians. Let's imagine we have Canadians drifting down from Ontario to use the Galleria, the big mall in Buffalo. And one of them slipped on a wet floor and had a concussion and had to go to a local Buffalo hospital. There's a Canadian in a Buffalo hospital. Not because they're seeking care they can't get in Canada, but because they had a medical episode, and that's what they show in great detail. So you should look up that reference. It's on page 276, note 4, and see what data they actually have. Reed also points out that the waiting list is very connected to the issue of budgetary politics. And when governments change or political priorities shift and budgets shift with them, then the waiting list problem diminishes significantly if it doesn't disappear entirely. He makes a very good point about this in a case called Chauli, C-H-A, I don't know how to pronounce it actually, C-H-A, it's somebody's name, O-U-L-L-I versus Quebec. There was a doctor who was dissatisfied that his patient wasn't being dealt with. He thought his patient was in great pain and suffering, and he made a case about it, not a federal case, but a provincial case of it, and took it to courts, proceeded through the system in Quebec, and then it was eventually settled. This is discussed by Reed on page 138, with a very, very surprising result. It was thought that if this case was successful, if the doctor's complaint that his patient was suffering unnecessarily and unduly because of being deprived the procedure that was said to not be available, then this would open the floodgates to privatization in Canada. There are always those who want to push for privatization, who are against the Canadian system. Some of that work is funded by the Fraser Institute, which has the Koch brothers and others like that behind them and so on. They don't like governments to work efficiently because they want free reign to rape and pillage the way they always do, etc. I'm talking about the earth and its resources, not so much human beings, although we have some of that that's going on lately as well. Anyway, the Koch brothers have not been involved in those kinds of scandals yet. We'll see what happens. In any case, the fear was that this case would open those floodgates and privatization would come marching in and the Canadian system would be ruined. But those in defense of the Canadian system, who were the vast majority, pushed back, and they realized, well, there is a problem, and the problem is limited resources. So instead of privatizing, we're going to put more money from the government into the system. And guess what happened in Quebec? The waiting problem was significantly solved. People, once you put resources into the system, were able to get access to care. The care was already first rate. People were dealt with successfully. The problem went away. So often, yes?
So the government put more money into reimbursing physicians then?
Well, it put money in the budget so that there would be more providers available, that the wait times would therefore...
So, but the providers are all privately run, right? So how is the government putting money into the single payer system increasing?
Every provider in Canada who takes Canadian patients is paid out of the government. Just as physicians here can have private patients who either pay out of pocket or have their care reimbursed by Aetna or Excelis, or by Medicare, whatever the insurer is. Same patient, same physician, different streams. So what this means is, in this case, more money is put into the Canadian Medicare stream. It's called Medicare, although it doesn't have the age restriction in the United States. So more money was put in, and more of those patients who were waiting for the procedure could move forward in the queue and have their needs taken care of. And it illustrates the point that, just as in England, there is a very, very close coupling between the budget of a system and how it works in terms of whether there's backup queuing or whether people move through it smoothly. In this case, the political circumstances, the court case and so on, motivated the Canadian government to put more money into the system, and the problem that had given rise to this case went away. So in Canada, there are also other complexities that don't show up in England so much. That is, Canada has a very provincial system. Think of it more like the division of responsibility in the United States between states and the federal government and so on. So we now have one state government, California, led by Governor Jerry Brown. California has a very robust economy. If you put it on international comparisons, it would be something like the 6th largest economy in the world, just California, some very dramatic number like that. And Jerry Brown is going to all these climate conferences and says, I don't care what Trump is saying. We in California, Americans, support climate, these rules and regulations, so don't say Americans are against it. Here we are, California's. So you have these kinds of tensions between the federal government, that's led by someone of Trump's political inclinations, and state governments, if it's led by a progressive Democrat like Jerry Brown or Cuomo in New York State. They have very different policies. The same thing happens in Canada. There is a government and a prime minister who's elected by general Canadian election, but the particular province might be far to the left or to the right of the national government. And when that happens, there are disputes and attempts at punishment and so on. And part of the reason that Quebec, where this happened, was punished with relatively low budgets was because of very major political differences between the central federal government in Ottawa, which is an Anglophone government, and Quebec, which not only is Francophone, but there have been Quebecois movements of independence. Quebec was going to separate from the rest of Canada and go on a very independent way, and this led to reprisals from the federal government, which was trying to get it back into shape and punish it. And one of the ways it was punished was budgets for its healthcare system. All this illustrates, whatever the particulars, is that we have to distinguish, continue to distinguish, between the structure and functioning of a system inherently and its budget. You can damage or ruin or fix and repair any system if you budget it adequately or inadequately. You cannot separate budgetary support from the structure of the system, and it's too easy and too often happens that people blame the results of poor, meager budgets, which may be based on political considerations, and can't distinguish the budgeting issue from the structure issue. The system could work just fine if it had adequate budget, and we have examples of that in Britain and in Canada. Now we turn, with 3 minutes left, to 2 examples. I'll try to do as much as I can, and obviously have to pick up a little bit on Monday. Taiwan and Switzerland. And we need to get certain things very clearly in focus. The most important thing is that these countries, when they embarked on their reform in the 1990s, did it with the clear notion of solidarity, as they would call it in Switzerland, or whatever the proper term was in Taiwan, they believed that there was a basic right to health. And as Reed points out, especially on pages 209, 215, 216, 219, 224, 225, all listed on that sheet as why the U.S. is different, how it's different from two. That has never been established in the United States. And it wasn't established as part of the Affordable Care Act. It is not part of Obamacare. There is no statement in it saying that there is a right to health care. The Obamacare is a fix, an attempted fix, of particular problems with ad hoc measures. It is not a transformation of values or moral stance. As much as Obama may have wanted it to be, it is not. And as much as it may be mischaracterized by those who oppose it, it is not. It is built within our system of market-based health care, trying to fix things and provide some more safety nets and apply a little bit more social justice, but it is not a transformation. On the other hand, there is a very different attitude in both, it was, and still is, both in Taiwan and in Switzerland. These two countries move forward, even though they were, and we have to recognize this, very capitalist countries. Both were when healthcare reform began. They were both democratic countries. And they both came to health reform in the 1990s as it failed under Clinton in that same period of time. The case of Taiwan is presented by Reed, pages 166 to 176, and the case of Switzerland is presented by him, pages 177 to 182. He begins his chapter, all right, I'm going to have to just wind up, by looking at the Cold War background to Taiwan. As one of the members of this class told me, who is from China, he said, we're talking about Taiwan as a nation. If you said that in China, you would be not arrested, at least suspected of treason. It's not a nation. It's part of China. And who lives there? The people who lost the revolution. That's how the country began. It's when they were pushed off the mainland as Mao was victorious. Anyway, so there's some of that review of what happened to Taiwan, how it was created as a nation. In the 70s and 80s, with big help from the US, it became a booming economy and one of the so-called new Asian tigers that had developed a very, very robust capitalist economy. By the early 1990s, country's leaders realized that though it was very democratic in most ways, its health care system was an atavism. It was a relic from some earlier time. It wasn't like the health care systems of other robust capitalist democratic countries, and it had to do something to move forward. So we're going to have to stop there. I will just very quickly go through Taiwan and Switzerland Monday, and then move to the U.S. history towards the Affordable Care Act.